Hi, my name is Dr. Lori Brotto, and I'm a professor in the Department of Obstetrics and Gynecology at the University of British Columbia. I'm also a Canada Research Chair in Women's Sexual Health and the Executive Director of the Women's Health Research Institute in the province of British Columbia, Canada. I'm really thrilled that I have the opportunity to speak to you today about some innovative approaches to the treatment of low sexual desire in women. And this is work that I've been focusing on for the better part of the last 15 years or so of my academic as well as my clinical career. We know that low sexual desire is very prevalent. National probability-based studies show that about a third of women will report ongoing and distressing low sexual desire or altogether absent sexual desire. And this can create a lot of stress and distress for the woman and for her relationship. So having evidence-based treatment approaches available to help women adjust and cope with and overcome problematic low desire is really quite important and has been the primary driver of most of the work that I do. In this presentation, I'm going to be focusing mostly on psychological approaches and in particular the evidence-based strategy known as mindfulness meditation. I'll share with you what that looks like, how it might help women with low sexual desire, and what some of the scientific evidence show us. So to get started, one of the things we know is that the characteristics of care providers, healthcare providers, is probably one of the most important factors that predicts how well women do in treatment. So care providers that are able to be empathic with women, ones that are well trained and have some solid knowledge base in sexual health and sexual medicine, healthcare providers that are perceived to be trustworthy, they're unembarrassed to talk about sex, those that have an ongoing relationship with their patient, the ability to fold in some humor. After all, it's not all serious business when we're talking about sexuality. Someone that's perceived to be a leader in their field and yet also can be taken very seriously. So these 8 factors are really very important when determining how women might respond to a particular treatment. And the reason I start with this slide is because there may be many care providers that don't have extensive training in sexual health and sexual medicine. Yet if these 8 factors are already in place, they can still be the first line of offering a therapeutic approach to women. So moving on from there, we know that education is very, very important when we're talking about sexual desire in women. Society, unfortunately, there are many myths and misperceptions about women's sexual desire that women unfortunately buy into. So myths such as people must be ever ready for sexual activity, and if they're not feeling in the mood for sex, that must be a sign that there's something wrong with them or that there's a problem in their relationship. So providing good, solid education that involves debunking sex-related myths and that involves providing some basic education, essentially the opposite of what this cartoon is depicting. We took off our clothes, I got on top. How soon before it starts to feel good? So a care provider that's able to ask very specific questions of their patient around what does your change in desire look like? How is that manifested? Can be a really important first step in treatment. So moving on from there, I have found over the last 15 years or so that using a circular sexual response cycle to help women identify where the breaks for them might be as they're attempting to experience sexual arousal and sexual pleasure. So to orient you to this circular sexual response cycle, at the very top it suggests that a woman's reasons for sex are really quite important for determining whether she's going to initiate sexual activity or respond to a partner's invitations. So in dialogue with a patient, asking a woman, what are your reasons for sex? And for many women with low desire, they're unable to identify any reasons. They have a sense that sex might be something important to them and to their relationship, but for them personally, they're unable to say why sex should be motivating for them. So to that end, I sometimes find that presenting women with a distilled down list, and this list of about 30 reasons, 30 common reasons that women provide for sex, is taken from a much longer list of over 200 reasons that has been identified through the scientific literature as reasons that women and men commonly give for why they engage in sex. Now, among the myriad different reasons, we know that some reasons are what we call approach-related. So in other words, having sex to gain something good, such as intimacy or closeness or the promise of sexual pleasure or orgasm. But sometimes reasons might be avoidance-related or reasons to avoid something negative, such as perhaps to avoid a fight, to avoid conflict in the relationship, to avoid unpleasantness in the woman's surroundings if she does not engage in sex. And what's important to realize is that if a woman's only reasons for engaging in sexual activity are to meet these avoidance-related reasons, that's sort of a perfect recipe for building resentment over the long term. So working with women to help her identify what are her reasons to get started off that starting block, and if she doesn't have any reasons that she's aware of, perhaps encouraging her to read through the list and can she try on some of these reasons that might motivate her to move from neutral towards open. So the next component of the circular sexual response cycle is addressing stimuli. And we know that sexual response, just like other emotions such as happiness or sadness, it is activated in response to a trigger. And so what this means is that stimuli become really important when we are considering what might elicit a sexual interest or sexual response for women. So by stimuli, this might include triggers in the woman's environment, so perhaps seeing a partner, having a partner say something sexy or tantalizing to her, perhaps seeing something visual like erotica or watching a partner undress. Triggers can also involve erotic thoughts or fantasy or having memories about a past sexual encounter that was pleasing to her. Whatever the specific stimuli is might be very particular to that woman for that stage of her life and within that particular relationship context, so that triggers that may have been effective for her at an earlier time in her life or relationship may not have that same potent effect in eliciting sexual response as they do today. So for some women who report low sexual desire, it really is due to a breakdown at that sexual stimuli part of the sexual response cycle. And so talking to women about what are the stimuli for her that really work for her to elicit arousal. And so as we move along here, we know that sensate focus, which is one of the longest standing techniques in sex therapy developed by Masters and Johnson in the 1950s and 1960s, that involves partners progressively touching one another, not for the goal of eliciting arousal, but really for the goal of eliciting awareness to touch and focusing in on sensations. Sensate focus can often be a helpful strategy for women who've lost sexual desire, and it's related to an inadequate amount of or ineffective use of sexual stimuli. So through sensate focus practices with a partner, can women become more in tune with the kinds of touches that effectively elicit a response for her. We also know that in the way of more erotic stimuli, there's been lots of scientific evidence showing that different types of erotica that are pleasing and acceptable to women, they tend to be the more female-friendly erotic forms of videos. And there's also evidence that the use of handheld vibrators and reading fantasy can also be ways of triggering the sexual response for women. So as we move along the sexual response cycle, it also becomes really important to recognize that even with a good level of motivation for sex around the reasons, having effective stimuli, that if the brain is not processing those triggers and is not translating that information into a sexual response, then arousal will not happen. And so there are a variety of both mental and psychological, as well as more biological and physical factors that can block this information processing from happening. One very common contemporary example is the effects of stress. And stress and distraction can effectively remove the woman's attention and awareness to those sexual cues and cause a block in that phase of the sexual response cycle. We also know that conflict in the relationship, so a woman who's maybe afraid of the outcome or concerned about a partner being unhappy with how the sexual encounter goes, and that may be rooted in some deeper relational or conflicted issues within the relationship, can also serve to block that aspect of the circular sexual response cycle. Depending on what's contributing to that block, the care provider might recommend a variety of different strategies. So it may be that if there are relational issues at play, that the recommendation is for some type of communication therapy or relationship therapy. Sometimes context is a factor. So if sex is typically happening in an environment that's not conducive to being present, being relaxed, feeling sexual, such as in an environment where the woman might be interrupted, where she has a fear of children walking in, where there are other visual distractions in the room, that also can directly block the sexual response from happening. Next on the slide, I have two evidence-based psychological therapies that have been tested over the past many years as a treatment strategy for improving sexual desire in women. In the way of mindfulness meditation, this is where a lot of my own research has happened. And unlike cognitive behavioral therapy, which is really about changing problematic thoughts and replacing irrational thoughts with more balanced ways of thinking, which would then positively impact mood and behavior, the mindfulness approach involves a more of an acceptance strategy. So it involves the woman accepting that she might be distracted, that she might be preoccupied with concerns of body image, that she might be worried about the outcome. And in accepting those kinds of thoughts and distractions, she's able to redirect her focus back to the here and now and tune into the touch and tune into the other sensations. So that's essentially the mindfulness-based approach. It's about not fighting what can't be changed, but reacting in a more effective way. We often use the raisin as a way of introducing mindfulness-based strategies to women seeking treatment for sex therapy. And the care provider can guide the woman over the course of 10 or 15 minutes to first visually look at the raisin, taking in all of the different visual aspects such as light and shape and texture. The woman can also be guided to feel the raisin in her hand, taking note of its weight, of the contours, of what it feels like in her against her fingertips. And then slowly she's guided to place the raisin into her mouth without chewing. And it's in that moment that she recognizes that salivation, which is the anticipation of biting into the raisin, and which can be a very powerful illustration of the body readying itself for ingestion. So an eating meditation with the use of a raisin can be a very powerful way of introducing women with low desire to the power of mindfulness. From there, in our own work, we've used a very structured 8-session mindfulness-based cognitive therapy delivered in groups over the last 15 years or so. This involves doing face-to-face mindfulness meditations with a group of women. They might be guided to focus on sensations in their body, in their breath, progressively move on to helping the woman incorporate mindfulness into progressively more sexual encounters in her life. Over the last many years, we've administered this type of mindfulness-based intervention one-on-one with women, either gynecologic cancer survivors with low desire and sexual arousal problems. We've administered it in group format over 4 sessions to women with low desire. More recently, we've moved to an exclusive 8-week group session for women with low desire. And we've also adapted this to women with low desire related to a history of sexual abuse or women experiencing chronic genital pain. And this body of research has found that in the short term as well as in the long term, when women are followed up for up to a year after taking part in a mindfulness-based approach, that they have significant increases and improvements in their level of not only sexual desire, but significant reductions in their levels of sexual distress. So moving on from there, if we've ruled out that the break in the woman's sexual response cycle is related to these sorts of distractions or other events in the moment, we then look at arousal itself. And for some women, difficulties with vaginal lubrication or vasocongestion are really at the heart of her low sexual desire. For women who are in the perimenopausal phase of their life, they might be experiencing vulvovaginal atrophy associated with reductions in estrogen, and this can give rise to vaginal discomfort or even pain for some women. And if a woman continues to experience this type of discomfort, understandably her level of desire for sex is going to decrease as well. So it becomes really important that we address for women, is there adequate moisturizer? Has she considered the use of a non-prescription lubricant, or perhaps in the case of vulvovaginal atrophy, some type of prescription moisturizer for her? For men, of course, there's the equivalent in the way of the PDE5 inhibitors that again are intended to increase peripheral sexual arousal. So for women, the focus on this phase is sexual arousal happening, and is it adequate for her to feel a physical sexual arousal response? If we determine that the break is not happening there, but really at this phase down here where despite feeling arousal, it's not triggering sexual desire for her. So the woman is sort of going through the motions, her body is responding physically, but it's not eliciting any sexual desire for the woman. That can often be very distressing for the woman because she's addressed her reasons for sex, she's addressed the adequacy of her stimuli, she's focused on being present in the moment and has eliminated distractions, her physical sexual response is intact, and yet she's still not responding in the way of that she would hope that her desire would respond. Those types of situations are far more rare and can be far more difficult to treat, and might be a candidate for some of the available medications for women. Moving on from there, if the outcome for women is still a lack of sexual satisfaction, even though arousal has happened and desire has happened, it would suggest that focusing on sexual satisfaction as the outcome might be the most the best way to focus therapy. And so for there, we often look at what are the other kinds of non-coital sexual activities that women that directly impact sexual satisfaction. The Normal Bar is a fantastic book that summarizes data from about 90,000 individuals from around the world. And what the study found is that one of the things that men and women miss the most in their long-term relationship are many of the non-sexual kinds of expressions, such as holding hands, using pet names, touching and kissing in ways that they used to at the start of the relationship, and that those factors were really key for them to feel sexually satisfied in their relationship. So I often recommend the book, The Normal Bar, and I normalize to couples in long-term relationship, the importance of really reintroducing some of those factors that were present early on in their relationship when desire and satisfaction were much higher, and considering reintroducing them even in long-standing and long-term relationships. Finally, I think that for some women, in fact many women, that having excellent books at hand that have been based on evidence-based material, a few of those are shown here on the slide that I commonly recommend to women with low desire, can be really important for helping the woman to feel that she's not alone, that her changes in her sexual desire make sense, they are understandable within the greater context of, say, her health or her relationship conflict at the time, but at the same time that sexual desire is something that can be cultivated. It's not something that women need to resign themselves to having no or low levels of desire in a long-term relationship. So I often do, alongside these specific sexual desire strategies, recommend any one of these books, and there are a host of other really excellent books that are very easily accessible to women. So in closing, my hope is that on the basis of this very short presentation, that viewers of this presentation understand that sexual desire is something that can be cultivated through a combination of education as well as some of the evidence-based psychological strategies, whether it's cognitive behavioral therapy addressing myths and misperceptions, or mindfulness meditation, which, as I've reviewed briefly, has been found to produce quite significant and even lasting improvements in sexual desire. And for viewers who are interested in finding out more about mindfulness meditation, many community centers offer group mindfulness sessions. There are also some excellent audio guides online and some fantastic books on mindfulness meditation. And coming out in early 2018, my own book on better sex through mindfulness that really guides women through the specific strategies that we've used in our own treatment program for cultivating sexual desire through a mindfulness-based approach. So thank you again very much for tuning in today.
Thank you very much, Dr. Brotto.
My pleasure. Hope that was okay.
It was wonderful. Thank you. So we had experienced here a moment where we couldn't hear anything. It was just fuzz. Was it our phone? Bonnie? Is it clear over there?
No, I had the same experience. I marked it down at around, it was page 13 or slide 13, at 120. And it's interesting how we never had any problems with the phone until, like, see, it's happening again now.
Yeah, I can hear it now.
Yeah, and so I don't know, because it's like she's on a landline.
Yep.
The only thing it could be is the speakerphone.
And I, as soon as I heard that, I picked it up, and so I actually held the receiver to my ear for most of the presentation.
Wow.
So maybe we have to do slide 13 again.
Slide 13? Okay.
Yeah. What do you think, Ba?
Yeah, because the fuzz is happening right now. That's what I'm worried about.
Yeah, I hear it too.
And we don't know where it's coming from.
No, because we were both.
Now it's gone.
Your line and my line were hard muted, so it has to be the phone line or the speakerphone itself.
Okay. Even though I'm not using speakerphone.
Oh, right. You're.
Cannot be the speakerphone.
Right. Okay. But I'm happy to repeat slide 13.
Yes.
So this is the one. This one here. Can you see it on my deck?
Yes.
Okay.
Yes.
And so were things fine right there with the slide before and the slide after?
Yes. And it wasn't the whole slide, but I don't know exactly where the fuzz is, so if you could just repeat the whole thing, we'll just edit it and insert it.
Sure. Yeah. So do you want me to start with this slide here then? Just say what I have to say about this slide.
Yes.
Okay. And should I press start on my end?
No. Oh, you stopped it. Oh dear, I didn't want you to stop it.
Oopsie.
Oh dear. Okay, hold on 1 second.
Okay.
Sorry. Oh, here we go again. Is it windy in Vancouver?
It's not windy, but it's raining pretty heavy.
I thought maybe it was the wind that was coming through. Maybe it's the rain that we're hearing.
Okay, so yeah, so let's just go ahead and start it again. So
Okay.
hit start, and I will mute them. And if the fuzz starts, I would ask you to stop.
Stop.
And wait till the fuzz stops, and
Okay.
then start again.
Sounds
Okay.
good. So over the past 15 years or so, we've created a treatment manual that contains many of the mindfulness exercises that we deliver to women experiencing low sexual desire. And we've compiled these into a treatment manual for the facilitator to be guided, as well as an accompanying manual for the women themselves that lists the exercises and has an accompanying audio file delivering the meditation sessions. So some of the exercises that we do include the eating meditation that we just discussed. We also guide the women through a body scan that involves inviting her to pay attention to different sensations throughout her body, including the erogenous zones of her breasts and genitals. In separate mindfulness exercises, we might guide her to pay attention to sensations of the breath. We do some in-session mindful stretching and yoga. We guide her to pay attention to sounds both in the room and outside the room. And we also use mindfulness as a way of paying attention to thoughts and distractions as mental events, not as prescriptive pieces of truth that need to be followed. So we do these exercises in group together. We encourage the women to practice these at home on their own. And then over the course of the 8 weeks, we progressively generalize these mindfulness exercises to more and more sexual encounters with, first of all, the woman on her own as she's engaging in a self-touch exercise, and then eventually while she's being sexual with a partner, where she can use her new skills of mindfulness to fully immerse herself in all the sensations that arise as she's engaging in sexual activity with a partner.
That was great. That was great. Thank you. We're glad that we could do that. So everything is going to be nice and clear. Thank you so much. Do you have anything that you feel you want to do differently or you want to do over, Dr. Brotto?
I don't know because I didn't sort of filter or monitor as I was going through. So I think I'm generally happy with how it went, and I think we could probably leave it.
Yes, I think everything was great.
Great.
So we will edit this audio video, and we'll send it to you for your approval.
Okay, that sounds excellent.
Before we post it on the website.
Okay, very good.
All right.
Good.
So we're done over here. Thank you very much.
All right, have a good day, everyone.
Yes, thank you. You too.
Bye now.
Bye-bye.
And Bonnie, are you still there?
I'm still here.
Excellent.
Yeah, the only
So
thing we could have done to, and it just started happening towards the end, right? The only thing we could have done was have her hang up and dial back in. Because even in traditional landlines, these things happen unexpectedly for no reason, and so the only way to clear it is to get a new connection. So, but thankfully, in the re-recording, the fuzz didn't come back. So
Yeah, the fuzz didn't come back, and it was only that moment.
Yeah.
There was never anything else. So I think it was perfect like this.
Okay.
Excellent.
And we were able to do it very quickly.
Bonnie, if you could send us this recording in addition to the last 4.
Well, we haven't received any.
The recording on the 20th,
Okay.
the 22nd, the 27th, and then the one that we did today. If you can send those to us via email, the email is going to be info@herdesire.net. And if you could send that, if you don't hear back from us, we're going to look into making sure. We just want to make sure that we're getting all of these.
Yeah, because we have not received those recordings yet.
Oh, okay. Well, they don't come straight from me, but I'll make sure to tell my boss that they have not been received and that someone should contact you right away.
Would that be Nadine?
Yes. Yes.
Okay. We'll tell her. Don't worry about it.
Oh, okay. But I do, every time I do one of these, I send a report with the details, so they will see that as well.
Okay. Thank you very much, Bonnie.
You're very welcome.
Oh, here comes the fuzz again.
I know. Maybe it's your line. I don't know. It's crazy.
All right. Thanks.
Okay.
Bye-bye.
Thank you. Bye-bye.